or what not, let's talk about clinical questions. And we will go interactive. So we'll keep on discussing things. So here's the first question of the day. All of you, yeah, here's the first question of the day. We'll have 20 clinical questions today. And the first question is of a 11-year-old boy. So this is our first question. A 11-year-old boy has a wide and fixed second heart sound. 11-year-old boy has a wide and fixed second heart sound. He has a murmur, grade 3 murmur on the left, middle and upper sternal border, and he also has a first degree heart block. So all of you, what is your diagnosis first, and then we'll talk about the association of this disease. So all of you, what is your diagnosis? Whenever I say wide and fixed second heart sound, so I will be taking your cardiology class as well, and then we will be telling you that whenever you think about a wide and fixed second heart sound, your first differential should be ASD. And this is a 11-year-old asymptomatic child. So remember, your differential diagnosis in a wide and fixed split of the second heart sound would be atrial septal defect. Okay. Now in atrial septal defect, now we are talking about an 11-year-old. We have not told you any symptoms. He looks like asymptomatic. 11-year-old asymptomatic child. You should think about ASD secondum. So you should think about ASD secondum. So all of you, this is, suppose this is your atrial septal defect, right in the center, at the level of foramen ovale, right in the center is a defect called ASD secondum, which is also called fossa ovalis ASD. Okay. So right in the center of the atrial septum is the fossa ovalis ASD. Okay. Then there is a big cleft in the septum on the medial aspect called primum, ASD primum. So there are some children who can get defect called primum. This is atrial septal defect. Okay. So on your screen is the atrial septum, and on the top is the superior vena cava joining here, inferior vena cava joining here. So at the sites of insertion of superior vena cava, inferior vena cava is sinus venosus ASD. Okay. Secondum, primum, sinus venosus. So all of you should know which is the most common ASD. 70% of all the ASDs is secondum. And remember, secondum is asymptomatic. And the only problem which you see during childhood in secondum is a wide and fixed second heart sound. So this is the only thing you'll see during childhood, a wide and fixed second heart sound. Okay. So I just showed you a child, though all of you, those who joined late, an asymptomatic child, 11-year-old asymptomatic child having a wide and fixed second heart sound. This is ASD secondum. Now you should know some syndromes associated with ASD. So all of you should know that there are some syndromes associated with ASD. Syndromes associated with atrial septal defect. Genetic syndromes. Okay. And first and the foremost, can anyone in the class tell me which is the most common syndrome associated with ASD? Anyone in the class? Most common syndrome associated with atrial septal defect. And the answer is, and we will talk about it today, the most common genetic syndrome associated with congenital heart disease. most common genetic syndrome overall associated with congenital heart disease? And all of you are wrong this time. The answer is Down syndrome. The most common genetic syndrome with heart disease is Down's. Remember, 30 to 40% of Down syndrome have a heart disease. 30 to 40% of Downs have a heart disease. And heart disease is the most common cause of death in Down syndrome. Okay, so heart disease is the most common cause of death in Down syndrome in the first 2 years of life. In the first 2 years of life, heart disease is the most common cause of death in Downs. And today we will be talking about it. The most common heart disease in Downs is AV canal defect. AV canal defect, which is also called endocardial cushion defect. AV canal defect, which is also called endocardial cushion defect. What are these cushions? Guys, you know, our septa are formed from cushions. So these cushions, you know, grow up and down and they make the atrial septum and the ventricular septum. So remember, the most common heart disease in Downs is AV canal defect or AV septal defect or an endocardial cushion defect. Now listen to me carefully, all of you. Listen to me carefully. ASD primum is a part of it. Okay. ASD primum is a part of AV canal defect. Okay. So all of you, now listen to me carefully and type. You can type in the chat box. So which is the most common ASD in Down syndrome? Primum. Okay. So the most common ASD in Down syndrome is ASD primum. Okay. Now overall I told you the most common ASD is secondum. Now the second syndrome which you guys need to know is called Holt-Oram syndrome. What is Holt-Oram syndrome? It is a familial autosomal dominant ASD secondum. So remember, in Holt-Oram syndrome we see ASD secondum. It's autosomal dominant. Okay. They can also have first degree heart block, atrial fibrillation, first degree heart block, atrial fibrillation. They can have a VSD. Okay. And they also have bone defects. So this brings me back to my question number 1. They also have bone defects. Like the most common is thumb abnormalities. So they can have absent thumb or absent radius bone. So thumb abnormalities or radius bone abnormalities are common in Holt-Oram syndrome. So guys, coming back to you to the question number 1. Here is a 11-year-old ASD secondum. Okay, he has a fixed and wide second heart sound. So this doesn't look like Downs to me. He's an asymptomatic child. So which anomaly, guys, would be common with ASD secondum? Most common. And especially when you have a first degree heart block also, you will go for thumb abnormalities. Okay. So remember, this is a thumb abnormality which is common in Holt-Oram syndrome. Okay. So you should think about Holt-Oram syndrome. Okay. Thumb abnormality, think about Holt-Oram syndrome. Okay. Especially with a first degree heart block, my diagnosis here is a Holt-Oram syndrome, and you will think about thumb abnormalities. Okay. Holt-Oram syndrome. You should also know about 2 more syndromes, but they are rare. Okay. Holt-Oram and Downs are very common. There is another syndrome called Lutem-Bacher syndrome. Lutem-Bakker syndrome, which is ASD with mitral stenosis. So Lutem-Bakker is ASD with mitral stenosis. Okay. There is another syndrome called Alice Van Creveld syndrome. It's a very rare syndrome, Alice Van Creveld syndrome, in which in addition to ASD, there is also an extra finger called polydactyly. Okay. So there is also an extra finger, polydactyly. So that question number 1 was Holt-Oram syndrome. So you will think about, you will get a look for thumb abnormalities. Okay. So on your screen is a typical child. All of you, this is one of my patient, and this patient came to me with ASD. And what I did was, I looked at his thumbs. Can you see on the left side he has 5 fingers? On his right side he has a distally placed thumb. So any child with thumb abnormalities, you should think about Holt-Oram syndrome. They can have triphalangeal thumb. They can have 3 phalanx in their thumb. They can have a triphalangeal thumb, absent thumb, rudimentary thumb. Okay? Triphalangeal thumb, absent thumb, rudimentary thumb. Okay. So guys, let's take you to the question number 2. Now, the typical style of your examiners is to ask something like this. Now, can anyone tell me what is your diagnosis? On your screen, question number 2, all of you, is a 8-year-old boy who has a history of cleft lip, cleft palate repair and repair of tetralogy of palate. Now he has a very classic face, a small mouth, small mandible, narrow palpebral fissures, prominent nose, cryptorchidism. So what is a syndrome which I want you to remember? In which syndrome do you have this classic face of cleft lip, cleft palate, cleft lip, cleft palate, tetralogy of palate, a small mouth? So all of you, this syndrome is called DiGeorge syndrome or velocardiofacial syndrome. Velocardiofacial syndrome or DiGeorge syndrome. So all of you should remember, this is a very classic case they will ask in your exams. A child with cleft lip, cleft palate, small mouth, micrognathia, narrow palpebral pressures. So this is called DiGeorge 22q11 deletion. It's a micro deletion syndrome called 22q11 deletion. So they have so they have cleft lip, cleft palate. Cardio, so in the heart they have tetralogy of palate or truncus arteriosus. In the heart they can have tetralogy of palate or truncus arteriosus. Truncus arteriosus. What is truncus? You know, it's a single vessel above our heart. So truncus is a single vessel above our heart. Okay. No aorta, no pulmonary artery, a single vessel above our heart. So there is no differentiation, no aorta, no pulmonary artery. Now remember, what is DiGeorge syndrome, guys? All of you should remember, it is hypoplasia of the third and fourth pharyngeal pouches. Hypoplasia of the third and fourth pharyngeal pouches. And now you see the beauty of integration, guys. Now I am teaching you a bit of anatomy and embryology as well, because as pediatricians and as all of you for your exam, you should be aware about these simple things. Hypoplasia of the third and fourth pharyngeal pouch. So what comes from third and fourth pharyngeal pouch? Thymus and parathyroids. So this child has absent thymus and absent parathyroids. Absent thymus, absent parathyroids. So all of you, any newborn with less calcium, hypoparathyroidism means hypocalcemia. You should always look at the thymus shadow. Any child with hypocalcemia, look at the thymus shadow because they may have absent thymus, absent parathyroids. Okay. So all of you, this is something which I want you to remember. Let me take you to a bit of neuroembryology. In our body, embryologically, we have pharyngeal pouches and we have pharyngeal clefts. Okay, I will not take you to anatomy, but I want to bring your attention to the third pharyngeal pouch and the fourth pharyngeal pouch. Can you see? Can you see? I'll zoom it for you. From the third pharyngeal pouch, we get inferior parathyroid and thymus, and from the fourth pharyngeal pouch, we get superior parathyroid. So if the third and fourth pharyngeal pouches are not formed, this child has absent thymus, absent parathyroids. Okay, so in your radiology class, you will be taught about how to look at thymus. Okay, so every child with hypocalcemia, look at the thymus shadow. Okay, yeah, so that will be taught to you in radiology. There's a typical sale sign on the chest x-ray of a newborn. Okay, you will be able to see that in the radiology class. So let's take you back now. And now I have given you a background. Now you tell me the diagnosis and the treatment. Okay, diagnosis and the investigation. On your screen, all of you, is a 25-day-old female infant has hyperdynamic precordium. Hyperdynamic. So, there is so much of activity in the precordium. You can see all the pulsations in the precordium. They're bounding pulses, loud single second heart sound, systolic murmur. Thymus is absent. So what do you think this is? So all of you, since I can see a hyperdynamic precordium, I would say this child most probably has a truncus arteriosus, a complete mixing lesion. It's a complete mixing lesion. Okay. So because of the complete mixing lesion, okay, this child has hyperdynamic precordium. Okay. And absent thymus. Okay. So I will go for microdeletion 22q11. Yeah. So this is DiGeorge syndrome or truncus arteriosus, which is common in these patients. This is DiGeorge syndrome. Okay. So all of you, this was a typical case of truncus arteriosus, a hyperdynamic circulation. Both vessels are not differentiated. The pulmonary artery and the aorta are not differentiated. So there are bounding pulses. Okay. Now that is why they have a biventricular hypertrophy, which can happen in truncus, and they have a prominent, all the aorta's blood goes to the lungs. So they have a prominent pulmonary vascularity. All the aorta blood goes to the lungs. All the lung blood is also going to the systemic circulation. So it's a hyperdynamic circulation. So your investigation of choice in DiGeorge will be a fish, a fluorescence in situ hybridization. fluorescence in situ hybridization. Okay, I'll go for fish for 22q11 deletion. Okay, 22q11 deletion. So this is a typical case, just a repeat of the previous case, D. George syndrome, 22q11 deletion. We will get a fluorescence in situ hybridization for the micro deletions. Okay, if you want to look at micro deletions, get fish. Okay, let's go further. Let's show you a typical micro deletion syndrome. Here all of you is a very friendly child. Let's take you to question number 4. It's a very friendly child, a boy who is mentally retarded, friendly, and look at his face. His face, I will not tell you one. Okay, I will not tell you what is the kind of face. You tell me, in which condition do you have prominent lips, मोटे मोटे होठ? Okay, ऐसे किसके होते हैं? Okay, prominent lips. Okay, so don't get me wrong, guys. Prominent lips, long philtrum, and there is also a ejection systolic murmur at the second intercostal space. In which condition do you have mote mote hot? Okay, don't laugh, guys. This is a typical phase of elves. This is a Williams syndrome. Williams syndrome have a typical prominent lips. Okay, so this is Williams syndrome, and let me show you Williams syndrome. But before I take you to Williams, please look, he has a systolic murmur at the second intercostal space because of pulmonary stenosis. Okay, so remember, this is a typical case of Williams. Favorite question of your examiners, Williams. What is Williams? It's also a micro deletion syndrome. It is also a micro deletion syndrome. 7q 11.23 deletion. It's a small exon missing. Again, I'll get a fish. So this is what you can see, this is a long philtrum, prominent lips, especially the upper lip, prominent upper lip, prominent upper lip. Okay, then what else? They are very friendly. They look like elves, elfin faces. Now what is classic is the heart disease. Remember, these children have supravalvular aortic stenosis. They have supravalvular aortic stenosis, peripheral pulmonary stenosis. Peripheral, it is not a valvular stenosis, it is peripheral pulmonary stenosis. Okay, and they look like elves. They also have a history of hypercalcemia. They also have a history of hypercalcemia. Okay, they have a history of hypercalcemia. Okay, so this was a typical case of Williams syndrome. Okay, cool. All of you, can you write cool in the chat box? So especially the upper lips are more prominent, but both lips can be prominent, but upper lips are more prominent. Cool. Let's go further. And now it is a a cool question, but I want you to know that your examiners want to ask you about this most common syndrome. Guys, can you tell me in which syndrome do you see hypotonia, epicanthic folds, brush field spots of the iris, and AV canal defect in the heart. Anyone? Down syndrome. So remember, in Down syndrome, I just told you today, you guys should know, when we are talking about genetic disorders, of course you should know about Down syndrome. The most common genetic mental retardation. The most common genetic mental retardation in the world is Downs. Now let's look at their face. Let's look at the face, all of you, of the Down syndrome. Look at the facies. This child, look at his face. He has a typical mongoloid slant. Okay. Look at his folds. I'll just show you his iris also. Remember, they have typical epicanthic folds. So the typical folds are the epicanthic folds. Epicanthic folds. Open mouth with hypotonia. In the iris, remember, they have brush field spots in the iris. They have brush field spots in the iris. Okay, brush field spots in the iris. Now if you look at the hands, guys, let's look at the hands and feet. In the hand they have a single palmar crease. Can you see this? Single palmar crease. This is called the simian crease. They have a single palmar crease called simian crease. And look at the feet. They have a sandal gap or a saddle gap. They have a sandal gap or a saddle gap. Okay. Now let's look at the little finger. The little finger is slightly flexed. This is called clinodactyly. Clinodactyly. The little finger is partially flexed. It's called clinodactyly because of the hypoplasia of the middle phalanx of the fifth finger. Hypoplasia of the middle phalanx of the fifth finger. It's called clinodactyly. It is slightly flexed. Now you should know the systemic problems of Downs. All of you should know the systemic problems of Downs. So question number 6 is on Down syndrome, systemic problems. So can anyone tell me? Question number 6. Anyone? Yeah, so all of you should know that 30 to 40% of Downs have a heart disease. We just discussed about the heart disease. Okay. Now we told you AV canal defect, endocardial cushion defect. Now you should also know that 10 to 20% of Downs can have atlantoaxial subluxation. So 10 to 20% of Down syndrome can have atlantoaxial subluxation. So you should know that they may have atlantoaxial subluxation. So we don't try to always do a Morose reflex in these children. We don't do a Morose reflex in these babies. Okay, we don't do a Morose. Okay, because they may have issues, they may have cervical spinal problems. Okay, now all of you should remember two more things. Number one, that Down syndrome, again 30 to 40% of them can have autoimmune thyroiditis. They may have autoimmune thyroiditis, so they may have hypothyroidism. So in every child of Down syndrome, you should get thyroid function test because this is something you can treat. Hypothyroidism is a preventable cause of mental retardation. So this is something you can treat. Okay. Lastly, but not the least, remember Downs most commonly have conductive deafness. Somehow, in your exam, they very commonly ask about deafness. Now, Downs most commonly has conductive deafness, but they can also have sensory neural hearing loss. Okay. So both kinds of deafness can be seen in Down syndrome, but sensory neural hearing loss is more common in Down syndrome. I'm sorry, conductive is more common, but sensory neural can also be seen in Down syndrome. Fine. Rest abnormalities are not seen in Downs. Okay. Can we go further, all of you? Cool. Let's go further. Yes, you are right. Someone hypothyroidism is more common, and someone really asked a very good question that leukemias are also common in Downs. ALL is the most common leukemia in Downs, but when they have AML, AML M6 is the most common, megakaryocytic. Okay, ALL is more common, but when they have AML, AML M6 is the most common in Down syndrome. Let's go further. So we talked about Downs, the most common genetic mental retardation, Down syndrome, related with increased maternal age. Okay. So M6 or M7, okay. M6 or M7. So M7 is also seen, okay. So M7 is also seen, okay. Yes, M7, okay. Yes. Okay. So M6 or M7, and you are right, M7 is also more common as compared to M6. Okay. Can we go further to the next question? Yes, it's M7, you are right. Here is a 2-week-old baby with dysmorphic facies with this karyotype, 47 chromosomes and extra 18 chromosome. What do you see in trisomy 18? Which of the following is seen in trisomy 18? Overlapping of fingers. Let's take you to Edward syndrome. Let's take you to Edward syndrome. Trisomy 18. The second commonest trisomy, Edward syndrome, trisomy 18. The second commonest trisomy after Downs, it is the second commonest trisomy. It is also related to maternal age. It is also related to maternal age, just like Down syndrome. Now these children, all of you, as you can see on the screen, these children are born IUGR. They have a prominent occiput, trisomy 18. They are born IUGR. They have prominent occiput, overlapping of fingers. Overlapping of fingers is classic in Edward syndrome. In Edwards, overlapping. So the second and fifth is overlapping the third and fourth. So the second and fifth finger is overlapping the third and fourth. Okay. Remember, hypertonia is classic for these children. Hypertonia. Normally, we always say hypotonia, but these children have hypertonia. Okay. Now remember, if we look at the anomalies, Yes, they can also have rocker bottom feet, abnormal feet, abnormal talus over the calcaneum, abnormal talus over the calcaneum. Now remember, GIT abnormalities are common in Edwards syndrome. They can have atresia of the gut, Meckel's diverticulum. So remember, GI abnormalities are common in Edwards syndrome. They can have atresia of the gut, Meckel's diverticulum in trisomy 18. The second common is trisomy, also related to increased maternal age. Also related to increased maternal age. Okay, cool. Let's take you to the next question. Now here is a classic case, and we are doing trisomy, so maybe you can have an idea what we are talking about. Again, rocker bottom feet. But look at this child, guys. He has central facial abnormalities, cleft lip, cleft palate, cleft lip, cleft palate. Now what will you think of? This baby has multiple anomalies, midline facial problems. This is the crux here. Midline facial problems and some brain problems. Eye problems, rocker bottom feet. What will you think of? Now this time, now tell me the answer. What is common in Pau syndrome? So on your screen is a Pau syndrome. So yes, even Pau syndrome can also have rocker bottom feet. So even Pau syndrome, trisomy 13, can also have rocker bottom feet. Yes, so what they have in systemically is called in the scalp, they have aplasia cutis. Aplasia cutis. What is aplasia cutis? It's a disorder of cleavage of skin. It is a disorder of cleavage of skin. Okay, disorder of cleavage of skin. So they look like plaques, sharply demarcated plaques on the scalp. Okay, they are sharply demarcated plaques at the scalp. So just a word about trisomy 13 called Pau syndrome, a rare syndrome. You saw Downs is common, Edwards is common, but Patau's is rare. You saw they have central facial problems. So if you ever have a child with cleft lip, cleft palate, cleft lip, cleft palate, and you also see they have microophthalmia, they have small eyes, microophthalmia. Okay, the eyes may be close to one another. Hypotelorism, eyes may be close to one another, called hypotelorism. Okay, they may have an extra finger, polydactyly. Now I told you, Edwards syndrome has gut abnormalities, but these are plaques, Dr. Ambesh Kumar. These are ulcerated plaques. Yes, ulcerated plaques. So in the brain, they have a condition called holoprosencephaly. So in the brain, they have lesions called holoprosencephaly. It's a abnormal cleavage of the brain. Abnormal cleavage of the brain. So you may have a child who may look like a cyclops. You may have a botus which looks like a cyclops, a single eye in the center. A single eye in the center, fused frontal lobes, fused lateral ventricles. Okay. Now in the skin, this is what I asked you today. They again have an abnormal cleavage of the skin called aplasia cutis. Abnormal cleavage of the skin called aplasia cutis. Okay, abnormal cleavage of the skin called aplasia cutis. It looks like ulcerated plaques on the scalp. Ulcerated plaques on the scalp. So we talked about common genetic disorders, all of you. Let's go further. Let's take you to the most common syndrome asked in your exams, guys. Here is a 4-hour-old female who has prominent skin folds at the neck. So basically she has web neck. Okay, web neck and lymphedema of hands and feet. Web neck, lymphedema of hands and feet. And this girl, this is a female child, mind you, has horseshoe kidney. You will think about Turner syndrome. You'll think about Turner syndrome. Historically, this was the first chromosomal abnormality known worldwide. Historically, this was the first chromosomal anomaly, the genetic disorder known to have a chromosomal basis worldwide. Remember, 60% of Turners is XO. 60% of Turners is XO. Rest are actually mosaic Turners. Some are XOXX, some are XOXY. So there can be mosaic Turners also. So today you saw that during infancy, this is the clinical presentation of Turner syndrome. This is the typical infancy presentation. Web neck, lymphedema of hands and feet. But Turners can also present during puberty with primary amenorrhea. So a girl comes to you with primary amenorrhea. So Turners can also present during puberty with primary amenorrhea. Okay. Now let's talk about the cardiovascular abnormalities. Now horseshoe kidney is not so common, but somehow it is commonly seen in Turner syndrome. But the most common abnormality is cardiovascular. Almost 2/3 to half of these children have a bicuspid aortic valve. So most common, 2/3 to half of these children have a bicuspid aortic valve. Okay. And then around 20% of Turners have coarctation of aorta. Then around 20% of Turners have coarctation of aorta. So if you ever see a child of Turners who is hypertensive, you should think about coarctation of aorta. Any child with Turners who is hypertensive, think about coarctation of aorta. Okay. So these are important points about Turner syndrome. Remember, some mosaics, especially XOXY, children who have both, they have some cells are XO, some cells are XY. It is important because these children are at risk of gonadal cancers like gonadoblastoma. They are at risk of gonadal cancers like gonadoblastoma. Okay. Let's look at other options here. Supravalvular aortic stenosis. I just told you. Supravalvular aortic stenosis is seen in Williams syndrome. Williams syndrome. And pulmonary stenosis, all of you, we will talk about this today. Till now in my class, I have just told you peripheral pulmonary stenosis is seen in Williams. But listen to me carefully. I'll just write it for you. There's a syndrome called Noonan syndrome. What is Noonan syndrome? This child just looks like Turner's. He's a child, this is a child who has a Turner's phenotype, but it is autosomal dominant, equally occurs in boys and girls. So Noonan's is autosomal dominant, equally occurs in boys and girls. So which is the most common heart disease in Noonan's? Valvular pulmonary stenosis. So remember, the most common heart disease in Noonan's is a valvular pulmonary stenosis. It can be seen in boys also. XY. They have hypertrophic obstructive cardiomyopathy, atrial septal defect. So boys or girls, it is autosomal dominant with Noonan's, have valvular pulmonary stenosis, hypertrophic obstructive cardiomyopathy, ASD. Now we have boys here, they have cryptorchidism, and girls of Noonan's, they do not have infertility. Now you know Turner's, all of you know from your school, Turner's are infertile females. They have streak ovaries. Turner's are infertile females. They have streak ovaries. But these girls just have delayed puberty. They are mostly fertile. Remember, in Noonan syndrome, females are mostly fertile. They just have delayed puberty. So please remember that. Dr. Rishabh is asking, why not E? Because this is a Turner syndrome. Now in Turner's, you don't see pulmonary stenosis, Rishabh. Pulmonary stenosis is seen in Noonan syndrome, not in Turner syndrome, Dr. Rishabh. Okay. Okay, can we go further? Let's go further. Now, the next few minutes we will dedicate to Mendel. We'll talk about some pedigree analysis. Okay, we'll show you some pedigrees and we'll do a pedigree analysis. Okay. So here is a 10-year-old boy whose father died of some aortic problem. Okay, so this boy, his father died of aortic dissection. His older brother also had the same problem of some chest pain. Now father's sisters also had problem. Okay, and sister, her children also have the problem. And his paternal grandfather also died in 40s because of aortic aneurysm. So these are aneurysms which are usually, they are very commonly, they run in the families. There are some aortic aneurysms. This is not Marfan's. It is not necessarily Marfan's, Shivam and many others. This is not necessarily Nikita Radham. This may not be always Marfan's, but many aortic aneurysms run in families in the autosomal dominant fashion. So what I saw here is, number one, whenever you see a case of autosomal dominant, three things you have to look at. All generations are affected. If all generations are diseased, it is dominant. If all the generations are diseased, dominant. Equally occurring in boys and girls. Can you see? Sister ko bhi hua, brother ko bhi hua. So equally occurring in boys and girls, it means it is autosomal Somal. Okay, listen to me carefully because every exam would have a pedigree like this. All generations are diseased, dominant. Equally occurring in males and females, autosomal. Now, father is also giving the disease to son. Father is giving to disease to the son. Okay. So that is important because then it means this is not X-linked. It is not X-linked. So all of you in your exam, before marking autosomal dominant, always look at that whether the father is giving the disease to son. Because if father is giving the disease to son, it is not X-linked. Okay. So this is autosomal dominant. So this will give you a clue that this is autosomal. Okay. So these three things you have to remember.